insight I had was I could get better and better and better at surgery, specifically removing a primary brain tumor like glioblastoma. And despite that, and despite temporarily improving that patient's neurological function by removing that tumor, hopefully, if I've done it well, we haven't hurt that patient neurologically, which is the goal. Maximal tumor removal with maximum function preservation. If we can accomplish that key balance in the operating room more and more and more effectively, are we altering the natural history of the disease such that we're improving the outcomes for these patients? And the insight I was having was more and more, no, because the residual invasive disease that can't be resected without altering that patient's neurological function is the ultimate cause of recurrence and patient succumbing to this disease, which unfortunately still happens within 18 months, which is the median survival for patients still to this day. The blood vessels, as they change into becoming brain blood vessels, as the blood vessels are sort of separated and covering and providing blood supply to the brain and the central nervous system, because the spinal cord is the same. The interface between the blood and the cells on the other side is actually multi-layered and complex. That in science is referred to as the neurovascular unit, because it's actually there are contributions from the neurons and the blood vessel, the components on the other side, and then the blood vessels themselves. So that neurovascular unit is referred to as the blood-brain barrier. So it's much more challenging to get things to move across that barrier in the brain as opposed to in the heart or in the kidney. Drugs that would cross into the heart from the bloodstream would not otherwise cross into the brain. So it's estimated that 98% of current pharmaceutical drugs do not cross into the brain. Getting therapies to move into the brain has been a huge challenge in medicine, and many efforts have been made to mitigate that barrier, either by developing technologies and systems that can cross the barrier from a biologic perspective using shuttling systems, ways to disrupt the blood-brain barrier with osmotic changes in the salt concentration across the bloodstream, and then this technology that we've been developing where we actually activate circulating bubbles in the bloodstream temporarily within an acoustic field with sound waves, and in activating those bubbles locally within a region of the brain that temporarily perturbs and opens that blood-brain barrier through a biomechanical interaction more so than a biological interaction. If we can activate those circulating bubbles within the blood vessels, then within the acoustic field, then we see this effect. We see this temporary opening and ungating of the blood-brain barrier, and entities that are in the bloodstream that wouldn't otherwise go in, everything from small molecule drugs, dyes, fluorescent dyes, antibody therapeutics, larger molecules, nanoparticle therapeutics, they can now access and enter the brain, whereas before they were not able to do that. And that only happens where you locally sonicate and activate these bubbles, and over a short period of time. So it's not open for days, it's actually open for hours or less in some cases. What we don't want to do is wait until the tumor already recurs, because once that's happened in the brain, patients likely having neurological problems, and that tumor is now a heterogeneous, complex mass that's going to be harder to treat. Traditional chemotherapies, you would argue, kind of bluntly go after the tumor by just causing essentially universal cell death to whatever takes up that drug. And so we'd rather target the residual invasive tumor cells with focused ultrasound, get the drugs in, but have those drugs be tuned to treat the complex biology and not necessarily hurt the neurons and the other components of the brain. That's the real end goal here.